Welcome to the Pod of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours. Get down in the cave and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
My guest today is Dr. Stephen Cavallino. Dr. Cavallino is a physician in Italy who specializes in prolotherapy and regenerative medicine treatments for musculoskeletal conditions. He has worked extensively in the field of regenerative musculoskeletal treatments, particularly focusing on prolotherapy injections to treat chronic pain and joint instability. Dr. Cavallino has contributed to the development of prolotherapy techniques and has helped train other physicians around the world in these procedures. He is the founder of the European School of Prolotherapy and has been teaching prolotherapy for many years worldwide. This European institution is accredited, and he is very interested in teaching more physicians throughout the world. We talk today about indications, dosages, and methods of administration, as well as the physiology of prolotherapy. Please enjoy this great conversation I had with Dr. Stephen Cavallino. All right, welcome to the Pod of Inquiry. I've got Dr. Stephen Cavallino, and he is near Modena, Italy right now. And thanks for coming on and joining us. We're going to talk about one of your areas of expertise is prolotherapy.
Yes, thank you for inviting me, and I'm so glad to have. I'm originally from New York, and I live in Italy for more than 40 years, and I'm specialized in emergency medicine, and I enjoy teaching prolotherapy throughout the world, and this is an opportunity for me to share this with you. I really thank you, Steve, for inviting me.
Oh, you're welcome. So most of the audience is very well aware of what prolotherapy is, but there's about half of our audience that's non-physician. So can you kind of just give a basis of the fundamentals, what prolotherapy is?
Prolotherapy was born about 70 years ago. Born, I would say, it was from the United States. That's when it really started. So to define what is really prolotherapy, it's an injection therapy to treat chronic pain of the musculoskeletal system. And the word prolo means proliferation. And also for me, as one of the clinical instructors, I also say it's a deep injection, because we want to inject the structures that are the connective tissues that are attached to bones. And those are our ligaments. The thing that's really important to your public, to people that are listening, but also for doctors that don't have any idea what prolotherapy is, we need to understand, and this is really important, we need to understand that the bones are connected by ligaments, and these ligaments are the strongest part of our biotensegrity model of our body. Mm-hmm. And if we can understand that tendons become aggravated, unhappy, because the ligaments are weak, then we have something to challenge. This is where we're going to be doing these injection therapies to fix the areas that are weak. So the question that I always say to all the doctors I teach, I say, do you realize that we have weak ligaments in the knee? If we have weak ligaments in the knee, that means the joint is going to be weak. And I always say all joints become weak, not because they're losing cartilage, it's because they're losing their tensegrity model, that skeleton that holds the bones together. Right. And this is why prolotherapy is so powerful to treat these ligaments. All we're doing is we're putting them, and we're treating the ligaments like if I'm tightening with a screwdriver, I'm making it. And so as you know, Stephen, this is so important that we understand that we can fix the musculoskeletal system and put everything back into order. And what is the final thing that comes out of this? We have less pain. And this is why we have patients that are set up to go for surgery. And I says, wait a minute, let me see. This is an option. This is a non-surgical treatment. It's an injection therapy using a simple natural solution, which is dextrose. And dextrose, which is glucose in Europe, And this really makes the difference because what you're doing is you're telling your body, I'm going to fix you and I'm going to fix you in the right way. But we all have to be very clinical. And this is really another important concept in my school that we teach at the European School of Prolotherapy that we could talk about later.
Mhm.
We need for every physician that does prolotherapy to be very clinical. Do not be fooled by other physicians that are giving you, oh, you have low back pain, you have a hernia, or you have this. No, you need to be clinical. You're going to be an excellent doctor if you're clinically diagnosed without being influenced by other doctors. Okay, so this is a long explanation for you, but I like to talk about it.
No, I think it's great explanation. But let me unpack a couple of things that you said there. So one thing is our audience is very familiar with D5W glucopuncture. I've had Jan Kershaw on a couple of times. So what percentage of glucose or dextrose are you using in your prolotherapy in contradistinction to the 5% for more of the glucopuncture?
Okay, that's a very good question because for the audience, we need to know the difference between glucopuncture, neuroprolotherapy, or subcutaneous prolotherapy, or also called perineural injection treatment. That's all subcutaneous 5% glucose or dextrose. Prolotherapy means deep injections, prolo, profound, and these are to the enthesis, and we can use 10%, 15%, and up to 25%. What happens here is the higher the percentage of dextrose, the more inflammation you're going to cause. What is prolotherapy actually doing? It's causing after 10%, it becomes inflammatory prolotherapy. Because we start a healing cascade. We want to tell the body, listen, these ligaments are weak and we need someone to fix them. And that's why we cause an inflammation, so that the whole mechanism of the macrophage coming to clean out the bad tissue and the fibroblast coming in to put in the new tissue, and the healing phase goes on and on. And this is the difference. It's just about using the concentration. But another fundamental rule, Stephen, is this. We think it's the solution. It's not only the solution. It's the needle that is peppering onto bone. And this is why we need to also cause a little bit of micro hemorrhaging of the enthesis area that will increase the platelets to get to the area, the growth factors to be released, and so on. So that's why the solution, yes, it's an inflammatory thing. Instead of 5% of glucopuncture, it's not inflammatory. And the prolotherapy is an inflammatory solution.
All right. So another term you mentioned, which has really become new to me over the last year or so, is the tensegrity of the fascia or the ligamentous structures. And previous to me learning this actually from Dr. Kershaw was we just perceived fascia as the stuff that's in the way of where we want to get to from a surgical standpoint. But it turns out that this is quite an eloquent and intricate system.
Yes, actually the fascia tensegrity. When I mean tensegrity, means the tensions from point A to point B to point C. These are all different forces. And if we think about how is a bridge standing, it's all about engineering. It's those tension wires that are holding up the bridge. And it's all mathematically calculated. And our body is full of these tensegrity points. So fascia, which covers the muscle, it can be involved in causing pain because it's very richly nerved. And so now, this recent year, past 2 years now, there's been a lot of investigation with these knowledgeable doctors that are physicians that are doing fascia tensegrity treatment with D5W. Remember that dextrose, and if you don't notice, dextrose has an incredible effect on neuropeptides that are being released, which is inflammatory. It turns those neuropeptides down to zero, and this is why we have an immediate pain relief. Even in prolotherapy, we think, oh, the patient says, I'm so much better after 3 days. It's not about the new tissue growth. It's the neuromodulation that your body's getting. So even in this whole model of tensegrity, it's really important that we understand the tensegrity model means that if we have pain, we have pain because something's wrong with the musculoskeletal system, and we need to focus on that area. That's why we ask our patients, "Where's your pain?" Okay, and then you have to look at the body in total. It's not. It could be coming from your lower extremity while you have a shoulder pain, and we got to look at that whole biotensegrity model. Steve, it's more complicated than just saying it like this. The doctors that become more familiar and they start to age with prolotherapy, you start to realize, I need to improve my healing cascade. How come it's not working? Sometimes it's not working because you're not realizing that those ligaments are really important to treat, and you're not treating them, you're treating the tendons, and the patients are not getting as better as if you were treating. So remember that all tensegrity in our human body is the ligaments are going to make the tensegrity model much better.
Mhm. So I think there's a lot more going on than just structural and mechanical. The more that I look into the tensegrity, it appears that there's a tremendous amount of electrical things that are going on in the fascia, communication with other structures, and there's a lot of interplay there. What's your take on, like, so one of the questions I have is, okay, so we have a ligamentous complex that becomes, let's say, lax or weakened. And let's say we use a non-traumatic example, because everybody can understand when you blow out a lateral ankle or something like that, that's going to really have a detrimental effect on that complex. But what about just the person that you referred to earlier with knee pain? What do you think the process is that leads to this laxity or lack of ideal mechanical integrity, if you want to put it that way?
It's a very good question, because you're bringing us, you're focusing on a joint, right?
Right.
So knee joint with age, so we can divide this up in a degeneration process, which is
Okay.
aging.
Right.
And with aging, what happens is we lose our cartilage starts to be consumed. The meniscus in the knee starts to become less fluffiness, or it's starting to lose also its tensegrity. And what happens is these two joints start to come closer and closer. And I always say, if the joints start to come closer to each other, what's happening to the ligaments? They're not changing. They're becoming weak now. They're becoming laxic.
Right.
And this is why prolotherapy with dextrose can tighten up those ligaments, where the human brain says, oh, we have a new model right now. That joint is more stable because Dr. Cavallino just injected these ligaments. We want to thank you for this. A simple understanding of this concept will make the body heal better, and the patients have an incredible response on pain for this, because to give you an example, the PRP, which is platelet-rich plasma, which I like to give this example, and I go to many conferences and I hear it's just a prolotherapy solution that you're adding, because what you're doing is you're proliferating, you're using if you put that just into the joint, unfortunately, just putting it into the joint is going to give you an immediate response. You're going to have the patient's going to feel better, but within 3 months, it's back to where it was before, because you did not understand what makes a joint strong is ligament prolotherapy. And I always say this to conclude this: ligaments love prolotherapy.
Okay. So is there maybe a component of like chemical denervation that may happen with the dextrose at 15% in the ligament, in addition to the mechanical regeneration? That I thought you explained the fact that you almost get this immediate relief of pain because of the down regulation of the peptides, as you described. But can we go into that just a little bit more? Because I'm trying to understand what other processes could be going on here.
Yeah, we have to understand that, the biochemical changes in the healing cascade. What's actually happening when we're doing prolotherapy in the first hours after prolotherapy, the injection, you're going to have a bleeding phase. And so the bleeding phase is when you're going to start having inflammation. The first week, the first 3 days is called the inflammation actually phase. And then your body's going to defend. Now, the reason why you have less pain is because dextrose has that neuromodulation, okay?
Right.
But you will tell your patient after prolotherapy, you will have pain. And if you do have pain, we want you to take your Tylenol, or you could take any, no, you will not take anti-inflammatory drugs. You don't want to stop that inflammation phase. You
Right.
want to take painkillers. After the third, fourth day, now you have what you call the phase where it's going to start proliferating. So you have your whole immune system is fighting to clean up the damage. Remember this: the biochemical action of glucose at the enthesis releases growth factors. We have various different growth factors that are being released by glucose. It's an irritant it's an osmotic effect to the structures that we're treating. But at the same time, when you're peppering on bone, you're causing periosteal bleeding. You're
Mhm.
getting a second release of growth factors that are coming from the platelets, like PRP.
Right.
Okay.
Right.
And so in whole blood, we have plenty of, just to make that point there, the periosteal bleeding is whole blood. The whole blood, we have many growth factors. And this is why, even in the history of treating with whole blood, it really works on periarticular structures. So the point is, what's actually happening is it's a natural process of healing. Your body is going to respond. What really actually happens, sometimes we're gonna see patients every 3 to 4 weeks, and we're gonna give them these injections to 3 to 4 times, if not 5 times. Some maybe more, some less.
Right.
Some of the patients are not going to respond. And these are the patients where you have to say, wait a minute, am I missing something? Did I look at the patient correctly? Is this a metabolical issue? Is the patient on vitamin D deficiency, hypothyroidism? There are many factors. And I say to these patients, just listen, I can't really help you. These are 3 treatments. I don't think it's going to work for you now. But what I can tell you is the long phase of healing, 6 months from now, you can tell me if you're better or not. And what happens is more than 50% of these patients that have not responded will respond in the late phase. And that's because their thyroid is shot.
Okay. So if someone's not responding as quickly as you'd like, and we all want instantaneous results now in our society, right? So
Yes.
you got to just kind of coach them a little bit and say, hey, just give this a little bit of time. Now, when you administer this, are you using it in conjunction with any local anesthetics for management of pain during the injections? And if so, how does the local anesthetic interact with the solution?
What I do in my practice and what we teach at our school is we want everyone to draw on the patient, draw out the anatomy, structures,
Right.
palpate correctly, and you make small anesthesia blebs, which is at 1% dextrose, 1% lidocaine is what we use. And we give a 1% lidocaine in a 5 cc syringe. I put 4 cc's, either saline or dextrose, and that's for the blebs, so they don't feel the needle when it's coming in.
Right.
Actually, it's just to make the patient feel comfortable. That's really important. That we do understand that we're treating a patient, so we have to make them feel comfortable. So this is why we give them the lidocaine. In all of our solutions, 15% or 25% or 10%, or whatever percent it is over 10%, the protocols are you will have lidocaine in those. And so we
Okay.
have formulas for this. So the lidocaine will be in the solution. It will last for 2 to 3 hours. And then the patient, if you don't have pain, it's because you're having a neuromodulation, because the dextrose is cleaning up the area that is in extreme proliferating pain.
Right. Now, are you guiding any of these injections with sonography, or is this all by tactile?
Very nice question, because we're looking more and more into ultrasound guided prolotherapy. Prolotherapy was, as I said, 70 years ago, born in the U.S. With Hackett, Hemall, and Patterson Foundation. This is the Wisconsin group. It was always taught to us palpation-guided prolotherapy with no guidance. And I've learned it that way, and I teach it that way till today, because you become so good on palpation-guided and you can be so precise. But we must not underestimate that we can also use ultrasound to bring us to a higher level of understanding and higher level of also treatment. So if you were just palpating, and let's say you're doing a shoulder, and there's a very painful area at the rotator cuff, and you have no ultrasound guidance, and you feel that the tissue is swollen, well, you can sense that there's some type of fluid behind there, but you have no guidance. What are you going to do? Are you going to put prolotherapy there, or are you going to think about, let me see, maybe this patient needs to be ultrasound? So in some of these cases, we don't have ultrasound training. You would have to go around that problem and try to fix it. Remember, all fluid, all effusions are caused by weak ligaments. If you fix those ligaments, those tendons will not cause the compensating mechanism, which is the fluid. So in the swollen knee or a swollen shoulder, and so it's more complex. But to answer your question, yes, ultrasound is growing, and it's going to be in our school, the European School of Prolotherapy. We're starting to teach that now, and we've just finished a mission that we had which is a training mission where I take physicians that have just learned basic prolotherapy to Bulgaria, and they do a hands-on treatment for patients. They treat each physician that's learning treats between 7 to 10 patients a day with a professional, advanced clinical instructor on his side. And these different classrooms we had were always palpation guided. This year we had two classrooms with ultrasound prolotherapy guidance. So that was very successful, and it was also to prove to the doctors that are doing palpation guided, look what you can see. And
Right.
so I think that's our future.
No, that's great. So how do you decide on what concentration? Because you've mentioned 10%, 15%, maybe up as high as 25%. What is your selection criteria to pick one dosage over the other?
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor.
I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of StemRegen.
In all standard treatment, all standard teaching prolotherapy, 15% is extra-articular structures,
Okay.
and all joint or intra-articulars are 25%.
Okay.
We are actually going, we're going towards less inflammatory solutions. We're starting to use a lot more 12%, 10% prolotherapy solutions. There are studies that have used 5%, which is non-inflammatory,
Right.
and they're seeing very good results because the inflammation is not only caused by the dextrose, it's caused by the needle touching the bone.
Right.
And the golden rule about prolotherapy is it's a safe, simple, and easy injection because you're injecting on bone. If you inject and you're not touching bone, you could be anywhere and you can cause danger. So this is why also the needle is considered at 5% a possible inflammatory. And so we are seeing also literature. There are studies now that have proven that 5% can be very effective and not be the solution.
Interesting. We've always kind of felt that any type of biological that you're going to use, whether it's peptides or some type of amniotic fluid, you need to kind of get that tissue ready. I call it fenestration, where you're making small little areas. So it's kind of like, I guess, before you paint your house, you prime it so that the paint sticks on it.
Yes, that's a good concept.
And so now, how do you decide whether to use D5 or, dextrose with whatever percentage that you're going to use for prolotherapy versus, let's say, PRP or some other regenerative technology?
Eating stem cells, right?
Right.
My protocol and what I try to teach everyone is we have this concept which is called KISS prolotherapy. Keep it simple and safe prolotherapy. Okay.
Yep.
So your question is, what solution would I use? Well, we first want to use dextrose. Okay. And according to what pathology we're looking at, what we're treating, if I'm going to do an elbow and the elbow is very, very sensitive to prolotherapy, and the higher solution that we're using, the higher concentration, the more pain the patient's going to have, and the aggravation is going to be probably a pitfall.
Mhm.
So in an elbow, I would probably use 10 to 12%. I was using 15%, and I'm seeing that the results are better. And this study that was done was on 5%, and it was better and almost equal to 15%. But what the change was in this study was the patients didn't have a lot of pain after treatment. We have to understand that the structures that we're going to be treating are important. The solution that we're going to be using is important. PRP is more painful, and so I like to emphasize PRP and PPP, which is the poor plasma, is so effective on periarticular structures. We need to treat the periarticular structures of the joints. There's no need to put it into the joint. You're always looking for that miracle joint change. The joint is suffering because everything outside is not. And I tell my patients, I says, listen, if this apartment building, the walls are falling apart, why are you going to put new furniture inside?
Right.
Furniture, you got to fix the walls.
Right.
So, when will I use stem cells? I would use stem cells if everything that I've used hasn't worked. So in my past 3 years, I probably did maybe 5 or 6 patients with stem cells. I did about 90% of my patients with prolotherapy, maybe 10% with PRP. I really look at my patient and says, if you can do 3 treatments with prolotherapy and it works, I'm not going ahead to do. Now, the subcutaneous injections with 5%, which is, we call it in Europe, neuroprolotherapy. In the United States, they call it perineural injection treatment. Jan calls it glucopuncture. We're all treating the same stuff, okay? We're treating the nerves. And I mix these together on every patient, and I like to emphasize this. Well, I'm one of the instructors. I'm teaching this therapy here in Italy, and we want to pass the word on because everybody should be doing this perineural injection treatment because this is the easiest, safest. You can't cause a problem in these patients, even with glucopuncture. It's so easy. And it's also very helpful for prolotherapy because I think they both work together.
Oh, I started hydrodissections about 3 years ago, and then we were just using normal saline initially, and then we started using D5W, and the results just went way up. And then spending some time with Dr. Kershaw, he gave more indication for subcutaneous applications as well as perineural. And we've seen amazing things with that. And we have not, while not everybody responds to it, like you mentioned earlier, we've not seen one adverse event with this. So it's a very safe thing. And
Yes.
and patients almost laugh when you say, I want to treat you with some sugar water. That's like, what are you talking about? We've got all these $1 million drugs and you're wanting to do, some D5W. And the answer is it's great because the side effect is almost none. And the efficacy seems to be incredible. And, so it's kind of nice to know what you just said. And I'm going to ask it again to make sure that I don't confuse the audience. But if they're already doing glucopuncture with the D5W, they could essentially go ahead and do prolotherapy just by changing where they're locating their injections.
Yes, that's correct.
Okay.
Those two work together. There's no contraindication to do prolotherapy and glucopuncture, prolotherapy and neuroprolotherapy. I don't see any. You did mention hydrodissection, which is an excellent term. It has been growing and growing. It's getting bigger and bigger. This is usually ultrasound guided, and you're hydrodissecting. And remember, when you have pain, I'm saying this for the audience, when you have pain, you have an inflamed nerve or nerves. And these inflamed nerves, if we can ultrasoundly see them and we can inject them underneath and on top of them, that's hydrodissection, you release. The glucose has an incredible effect on nerves. And there's studies on this, and there's literature that backs it up. So we all know it's, these TPVR1 receptors are being taken up, and then they're firing out all these neuropeptides. And if we can, put the glucose in there, it'll work. But I can tell you one thing, Steve, not too many doctors talk about this, but if you have a patient that's on morphine or any type of even codeine that are on I would say morphine similar drugs, they are blocking the receptors where glucose can go and take away their pain. So these are the patients that will not respond to glucopuncture, will not respond to neuroprolotherapy, will not respond to perineural injection treatment because all the pain fibers at the skin level are being the receptors are being taken up by these morphine similar drug. So that's an important fact so when we do these and it's not working, I say, how come it's not working? Well, it's not working probably for this reason, because you're on morphine or you're on any type of drug that has morphine similar effects. Also, the dextrose, we have to check the pH of the dextrose. That's also important because if the dextrose is too acidic, it's not going to work. Talking about subcutaneous. And so it's a challenge. It's great. It's very easy.
Now let's go to your protocol a little bit. Let's say someone comes in with knee pain and you want to do, some prolotherapy. We've talked about how you're administering it, what dosage, but what do you do post infiltration? Are you keeping them non-weight bearing? Are you partially weight bearing? How are you managing these people?
Okay, that's a very good question. The post-treatment, what do I send the patients home with? Well, my protocol is when they first come in, I sit down with them and I say to them, what are you here for? Where's your problem? Tell me about it. And the first thing they do is they come and they says, here. I says, no, I don't want to see that. I want to see that later. I want to listen to you. and I put them on the bed and I visit them. I give them a good clinical evaluation, a good clinical examination, and I get an idea. And I says, I think I know where your problem is. So to give me an example, it's a knee problem. Okay. You have weak ligaments. I'm going to fix the weak ligaments and your joint's going to feel better. It's going to take you 3 to 4 treatments, and I'm going to see you every 3 to 4 weeks. Remember, when I send you home, I want you to listen what's on the paper. I'm going to give you a paper that says what you have to do. So I have a take-home paper, and this is my protocol. You're not supposed to be taking any anti-inflammatory drugs. You're going to take painkillers. Okay, so I tell you take Tylenol twice a day for 3 days. If the pain is too high, for example, I did an elbow and I put too much solution in and I hurt the patient, there's no problem to use an anti-inflammatory. You want to stop that fire. You cause too much fire. So I tell a patient, take 1 ibuprofen, 600 milligrams, and it'll put the fire out. And then you continue on. But your best friend is heat. Do not use ice.
Right.
I always tell them to put a heat compress on after the treatment, and they all tell me, and this is what we're sharing with everybody. Remember, heat is your best friend, because when you take a shower, oh, I feel so much better.
Right.
Your body's talking to you. And I even mentioned to one of the doctors. I said, I banged my head against the wall, against the shelf. Oh, that was in so much pain. What do? We rub on it, and it goes away, the pain. It's the heat.
Right.
So, why heat? Because it brings noble oxygen to the healing cascade that we want to call. So that's really important. Then a good thing, you tell them that you don't want them to rest in bed. You just say, listen, treat your body like a newborn baby. The first week, be gentle. The whole mechanism of healing is going to take place. That liquid that I put in will break apart if you start running and you start playing tennis again and so on. I want you to listen to your body. And then if some cases, I would tape them with Kinesi tape, or I would give them a splint. It depends what area we're treating. So for example, it's low back pain. I would tell them, listen, I don't want you to over-exercise. Don't go to the gym for a week because your back needs to be stable. Now, we have to look also at their posture.
Right.
It's not correct. So there's many factors. But what's really important is they understand they need to treat their body with the 1 week of, let's take it easy.
Yeah, I think you make a great point about ice. And it's been so universally put into every medical paradigm: rest, ice, compression, elevation. And even the guy that came up with that acronym is a physician named Gabe Merkin. And I did an episode with a gentleman named Gary Reinl that wrote a great book. I think it was titled Coming Out of the Ice Age, showing that how it's contra to regeneration. It's slowing healing down. It's trapping more fluids in the lymphatic system. And even like a lot of the great plastic surgeons today in the US are if they do a facelift, they don't want ice anywhere near that patient because it's going to compromise their outcome. And I think the only thing with ice is it does give somebody a little bit of an analgesic effect. But generally speaking, what I've found is that nerves really love warm, gentle heat.
Yes.
So that's a great point.
You mentioned something that's really important. This is going to be in our next masterclass in Europe. We have a masterclass every year where I bring the top-notch physicians together and we actually exchange all our education learning. The lymphatic system. The lymphatic system, if we can decongest the lymphatic system, the lymph nodes, we will increase our healing. It's an anti-aging process. And there's so much information that I'm going to be bringing out to the world in this masterclass. Hopefully, this is why when we treat with perineural injection treatment, which is we're aiming for the nerves, we're not doing glucopuncture. We're following the mapping, the nerve mapping. This is why the nerve regeneration therapy with PIT or neuroprolotherapy works, because it regenerates the nerve. Who's controlling the lymphatic system? The nerve. Who's controlling the tendon? The nerve. So the nerve, with Hilton's law, says this is the root of all our problems. So if we can fix it, look at a diabetic, has neuropathy, lower extremity neuropathy. Why is this? his whole vascular system is blown out because of diabetes. If we fix the nerves, he fixes the vascular system, the lymphatic system. I'm telling you, Stephen, this is the treatment of choice. We should start expanding this information throughout the world. Neuroprolotherapy, perineural injection treatment is subcutaneous glucose at 5% is so powerful.
Oh, you're preaching to the choir. I've seen it. I mean, I've had patients cancel knee replacement surgeries because we gave them 2 or 3 glucopuncture treatments. And it's like, why? I don't need to have this surgery because all my pain is gone. And it's amazing how, I don't want to bash orthopedics too much because they're my colleagues and friends, but it seems like we've had more and more patients over the last, 5 years or so, that you look at their x-rays and it's not bone on bone, and you're going, why are they going to do a total knee arthroplasty on this? Yeah. And a lot of times it turns out to be just a little bit of an entrapment of the common peroneal nerve or something like that, and we can take care of it very easily. But that's great. Now, I want to get to your school because I think a lot of our listeners will be very interested in this, and it's a good excuse to come to Italy, quite frankly.
Yes. Well, the European School of Prolotherapy was born in 2018, but before that, it was the Italian Association of Prolotherapy, and we formed this teaching standardization method of prolotherapy many years ago, and we formed a school for a reason, because this is something we have to pass on. And it doesn't only teach prolotherapy, we teach neuroprolotherapy, perineural injection treatment. We will have Jan with us probably doing glucopuncture. We do ultrasound guided, we do ultrasound training. We also do cadaver labs. So there's so much that is involved. But what is the key is, step 1, you got to do basic. Step 2, you got to do training. You go to a mission. Step 3 is you go to a master class. It's all connected. There's no reason why I should take someone in his basic learning that has just 1 year experience and put him into a master class. He doesn't know what's going on. It's too complicated.
Right.
Well, like I said to you before, it's KISS. Keep it simple and safe. Prolotherapy. That's the way our school runs. We give these courses twice a year in Italy, in a beautiful city, Ferrara, which is near Bologna. And the course is in 3 days. It's really a full 3 days of brainstorming. And I actually tried to make this possible because a lot of people traveling from all over the world can't come in for 3 different weekends. So we finalized it. We're going to do it in 1 3-day course. And what happens is that they come after studying all the lectures that they're going to go through, because we give them the lectures a month before. And so when they arrive, we go quickly through the lectures, and then now it's all hands-on palpation. This is the position you got to be when you're going to be palpating. This is the position we draw, Stephen, we draw on every patient. That is a mandatory rule. I just finished with Dr. Murat in Turkey. We just finished the first textbook of prolotherapy. This book will be coming out in about 2 months. It's 800 pages. It has everything you need to know about prolotherapy, about healing. It has nutrition inside, physical therapy, how to tape a patient, how to palpate, endocrine, understanding hormones. There's so much information in there. This is the future. Right. And I want to just underline one thing. Orthopedic surgeons that I taught prolotherapy to, I get the goosebumps by saying this. They said, Stephen, you changed my life. I still operate, but I look at the patient totally different. And it's just so incredible. Patient comes in with knee pain, post-operative prosthesis. They had a knee replacement. Can't get him better because the nerves are so messed up. We do, like glucopuncture, I do the articular nerves. You got to know the articular nerves.
Right.
You treat them, they are maybe 30, 40% better. It says, oh my God, what did you do? I didn't use any anesthesia, glucose.
Right.
we have so much to share. And I'm so glad to
Absolutely.
have this opportunity to explain my passion to all of you. And I invite you all to come to the school. To find me, you can look up www.prolotherapyschool.com.
I will put that in the show notes for everyone. And when's your next course?
Okay, we're going to have a neuroprolotherapy course, or the perineural injection course, the 15th and 16th of February in Ferrara, Italy. The prolotherapy course is going to be the 14th, 15th, and 16th, I think, but I can send you the dates. April of 2025. And we're going to have our master class at the end of May, which is going to be in Montenegro, Europe.
Mm-hmm.
And we have the mission that's open. Now, the mission is open to only doctors that have taken a basic course. Now, if a doctor wants to come as a refresh, I've taken a course, but I want to come again, then, we might invite them. And that is going to be the first week in September, from September, I think, 1st to the 7th in Varna, Bulgaria.
Wow.
And that is incredible. We just had one. We just finished the one in September. These doctors, there were 3 orthopedic surgeons there. They said, I can't tell you how much I learned. And it's because you're actually injecting patients under my license, because I'm Bulgaria. I have a Bulgaria license. We want to keep it simple. Nobody's going to get hurt, but I'm responsible for everyone injecting. And I'm telling you, there's no place that you're going to learn this unless you're doing this practical work. Sometimes I have doctors come to my office and I have them train with me in the office.
No, I think that's a wonderful format, the way you've laid out your school, and then the ability to actually have clinical implementation underneath a mentor or a master. That's kind of pretty much the ideal way to train somebody how to do things. So that's really great. Well, Dr. Stephen Cavallino, thank you so much for coming on. And I think we'll probably be visiting more in the near future. So thanks so much.
Yes, I'm really, it's a pleasure to share with you, Stephen, and your whole group there. This is a fantastic opportunity for me to express everyone out there. Start to be interested in coming out to see us. Even if you don't want to join the school, it's okay. But if you want to come and learn something in the following courses, that's fine. I'm open to everything. Thank you very much.
You're welcome. Make sure you let me know when that textbook's available, okay?
Yes, it will be available soon.
Okay.
It's incredible. I can't believe how much time we put in, but because we want this to be standardized. It has to be standardized. We can't be teaching differently than everyone. Everyone has to do it this way. Simple. All right?
All right. Thanks so much.
Take care and have a great time together with all your friends. Take care. Bye-bye.
Thank you.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardio protection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates.
Thanks for watching. You can start today.
I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.